Hello, good morning, good afternoon for everybody. So today we have the multidisciplinary case discussion. We have the three cases from the world, all over the world. So my name is Shintaro Iwata from National Cancer Center Hospital Tokyo, and we got three very exciting presentation. And so I hope you enjoyed today's session. Okay, let's get started. The first one will be the Dr. Sebastien Labonte from the Quebec, Canada. Okay, please start.
Hello, everyone, and I thank you for the opportunity to present a case today. I'm Sebastien Labonte. I'm a pathologist at l'Hôtel Dieu de Québec. You've probably never heard of Quebec City, especially not of my hospital, but we're one of the 3 sarcoma reference centers in the province of Quebec, and we're serving a population of 2 or 2.5 million people. So I cheated a little bit in my presentation because technically speaking, I'm not presenting a sarcoma, but I think you will find it interesting nonetheless. Oh, hang on, I'll share my screen. So the story begins, it's a 39-year-old woman who has had progressing left knee pain for a year. MRI in August 2019 showed a multilocular lesion with fluid levels in the left distal femur with an enhancing focus. And radiologically, it was highly suggestive of an aneurysmal bone cyst, possibly secondary to a giant cell tumor of bone. Unfortunately, I have not been able to retrieve the MRI images because they were done in another facility, but I have obtained the CT scan images, and they show a lytic lesion in the distal metaphysis epiphysis of the femur. It is rather well circumscribed without a sclerotic border, and there are internal septum, as you can see. You can probably also see on the third images on the right, there's a small lytic lesion in the patella and a small area in the posterior part of the proximal tibia. They were described by the radiologist, but they were not highly specific. So what treatment would you choose? And I have not done a Zoom polling slide, so maybe Mr. Moderator, you can open the lines for 1 minute to obtain people's feeling about it.
Okay, what treatment would you choose? We have the 4 selection. One is the curettage and cement. Second one is the biopsy, followed by curettage and cement. And third one is the unblock resection. And the fourth is the other. So, is there any opinion from the panelists?
I will start from the biopsy.
Okay.
Piotr, yeah. So, because still, I think that it's worth to be sure what is pathology.
Agreed. Start with biopsy. Thank you, Piotr.
Good. So,
thank you.
Let's go back. So on 27th of September 2019, like 4 years ago, almost day for day, a biopsy with frozen section was performed, and I saw it myself, and it was a giant cell-rich tumor that was compatible with a giant cell tumor of bone. As you know, there are like 7 possible differential diagnoses, but with the clinical and imaging features of that case, I felt confident that we had a giant cell tumor of bone, possibly with secondary aneurysmal bone cyst. And the surgery was completed immediately thereafter with curettage, burring, phenol injection, and cementation. Now, as pathology goes, the paraffin sections confirm what was seen on frozen section. That is, multiple giant cells are present, and they are rather homogeneously distributed. Higher power shows that the mononuclear cells have an ovoid nucleus that is very similar to that of the multinucleated cells. There is red blood cell extravasations, and other sections show a little bit of osteoid substance deposition, but no malignant cells. There are also areas that contain a more fibrous background and where the mononuclear cells have a spindled appearance. These are the so-called fibrohistiocytic changes. They are very common in giant cell tumor of bone and also in multiple other conditions. They are not specific, but they're totally consistent with that diagnosis. Other sections show little fragments of bone embedded in the tumor, and also fibrous tissue in a configuration that would be compatible with the wall of an aneurysmal bone cyst. And these fibrous bands also contain multinucleated giant cells, and that fits very well with an aneurysmal bone cyst, either primary or secondary. In that case, I was confident that we had primary giant cell tumor of bone with thus secondary aneurysmal bone cyst changes, and that's what I gave as a final diagnosis. Now, you're probably asking, why is he telling us about that case? Now, at follow-up 3 months later in December 2019, the MRI showed 2 small enhancing zones at the interface between the cement and the bone, and that correspond to little zones of osteolysis on the CT scan. The lesion in the patella was stable, but the lesion in the proximal tibia had progressed from 5 millimeter to 12 millimeters. That was a bit annoying, but the team chose to observe. Now, at follow-up at 3 months later, so that's March 2020, the MRI showed progression of the signal anomaly around the cement. The lesion in the patella was stable, but the lesion in the tibia had grown from 12 to 16 millimeters. More importantly, the patient was not feeling well. She had aches everywhere. She was weak, and she now had pain in the right hip, the right tibia, bilateral ankles, and that pain had been progressing for the last 3 months. I remind you, she had been operated in the left femur, so now she had pain all over the place. And this is the MRI from March 2020. I am unfortunately not very good to interpret those images, but you see on the left, there is the signal anomaly in the patella, and on the right, there's a big signal anomaly in the proximal tibia that even I can see. And I would not dare to interpret the signal enhancement around the cement. That is way beyond my competence. Now, what is happening? I see a raised hand. That will be great. So what's happening? It must be a manifestation of COVID-19. The pathologist was wrong in his diagnosis of giant cell tumor with aneurysmal bone cyst, or the patient has another disease on top of an aneurysmal bone cyst and a giant cell tumor, like, I don't know, a metastatic carcinoma or whatever. So maybe it would be a good time to get people's opinion.
Thank you, Sebastien. And okay, it's a very interesting and an unusual case. So, is there any opinion about this case? Okay,
Well,
Andrea?
there are several issues. You could have multifocal giant cell tumor of bone. This could be, I mean, she doesn't have hyperparathyroidism.
Absolutely.
And C, did you do a G34W on the primary to confirm it was a giant cell tumor of bone, or do a FISH for USP6?
Yeah, so we are always not rely on frozen material in such situation. We perform molecular testing with histone, and also, of course, if it's multifocal, we always have to exclude parathyroidism. This is parathormone level should be evaluated.
I agree with you. So that's exactly what happened. Now, the astute orthopod, who is not online today because he's on call in other facility, but he said also, there's something wrong. So he ordered other tests. And here are the blood tests, or some of them, a very high calcium level that is critical, a low phosphorus, a PTH at 937. That's almost 10 times the upper limit of normal. but a normal creatinine and blood urea, so she has no kidney failure. And obviously the results are quite consistent with primary hyperparathyroidism. Now, obviously other tests were made on the spot, and this is an X-ray of her hips. Even I can see a lytic lesion in the right intertrochanteric area, but there were as well many other lytic lesions in several bones. You can see them there. She also had kidney stones with hydronephrosis, and guess what? She had a mass in the neck, a quite sizable mass, in fact, 3 centimeters in size. So they immediately took care of her electrolyte abnormalities and her hydronephrosis, and like a few days after that, she had a resection of her neck mass. And obviously there was a parathyroid lesion, but the story does not stop there. So in the lower part of the screen, you see the normal parathyroid gland, and in the upper part, that's the tumor. In between, you probably see a vein, but don't worry, we'll see it on higher power. We see it here and even here. You see that the vein is partly thrombosed. The pink stuff in it is fibrin, and immunohistochemistry for PTH, parathyroid hormone, shows clearly individual cells embedded in the fibrin. So there is really a venous invasion. This is one of the criteria used to make a diagnosis of parathyroid carcinoma, which is very, very, very rare, as you know, and sometimes familial. So the diagnosis on this neck mass was that of a parathyroid carcinoma with focal microscopic contact with an inked margin. Only 2 lymph nodes were resected, and they were negative. Now, we're now 4 years down the road. She has no evidence of metastatic disease. She is obviously very closely followed in endocrinology, and they checked for any kind of hereditary syndrome. She doesn't seem to have one. And interestingly, she is now asymptomatic of her bone lesions. However, they have not completely recovered, or they have not recovered from a radiologic point of view, but she is asymptomatic. Now, the final diagnosis after follow-up is a brown tumor of hyperparathyroidism, secondary to a parathyroid carcinoma, mimicking a giant cell tumor of bone with secondary aneurysmal bone cyst. And it's not high-flying, molecular stuff. It's just elementary pathology principles, but it's good to be reminded of them from time to time. So the skeletal changes of hyperparathyroidisms are widespread. They involve all the bones, but they may appear localized clinically or even radiologically, especially early in the disease. Obviously, when they evolve, they can create severe deformities and fractures, and the full-blown manifestations is known as, as osteitis fibrosa cystica or Recklinghausen's disease, not to be confused with NF1. Mr. Recklinghausen's was a very prolific scientist. And it is one of the classical traps of pathology in which I fell. The brown tumor can be confused with an ABC or a giant cell tumor of bone. Now, interestingly, as someone pointed out, and as you know, the vast majority of giant cell tumors of bone have a mutation in a very specific codon 34, and the vast majority of these mutations is G34W, which is detectable by a commercially available antibody. And well, that's it. Unfortunately, I did not do that test. And that leads me to some take-home messages or take-home questions. And I would be happy to hear what you people do all over the world. Should we do systematic use of adjuvant techniques such as immunohistochemistry for every giant cell-rich tumor of bone? Should we do systematic pre-op blood tests or calcium metabolism tests for patients undergoing surgery for giant cell-rich tumor of bone? And also, I wish to emphasize the century-old wisdom that histologic diagnosis of bone tumor definitely has to be correlated with clinical and imaging findings, and also with careful follow-up. So no high-flying science here, but just plain old pathology principle that even in 2019, I tend to forget, but not in 2023. So that's it for me.
Thank you. Thank you very much, Sebastien. Okay, from the point of the pathologist, Eva, please state something about this.
Yes, thank you very much for this very nice presentation. It was very impressive. Also, the radiology about this. In fact, just in the beginning, I was already asking myself, first of all, would you ever do frozen sections on bone tumors to diagnose the entity? At least we don't. We don't want that. Also because often you have to decalcify the material and it's difficult to cut. And as you've seen, it might be also misleading. The other issue is, of course, the immunohistochemistry you mentioned. I mean, it's a very easy and also cheap approach without doing any molecular pathology, and you get the result on the next day to see. So at least we do, if we get a giant cell-rich lesion out of the bone, independently of the radiology, we perform this immunohistochemistry, because of course you will miss those 5% of other mutations, and then you have to do molecular pathology, but I think it's very easy. I wouldn't do pre-op blood calcium test, and of course it's very important that orthopedics learn, if they not already know, that it's useful to look in more parts of the bone than just the lesion where the pain is, because this would be of help. I mean, you've seen already in the beginning that there was more than one lesion, and in these cases, of course, would be helpful to perhaps look for the rest of the skeleton. Thank you.
Thank you, Eva. And also, Peter, do you comment?
Sorry, I was muted. I guess the comment is I mean, I sign them out, but I do the stains for G34W just more for interest. And if they're positive, then that's the end of it. If they're negative, I might start thinking about something else. B, we do frozens on most, if not all, bone tumors. I don't see anything wrong with that. It's easy to do. You can cut bone as long as it's not cortical bone, so I don't find anything wrong with that. And C, I wasn't convinced this was malignant parathyroid carcinoma. I was wondering if you did parafibromin stain to see there was loss in this parathyroid tumor.
No, we did not. I showed you the one venous invasion that was the best, but it was pretty convincing, and also extracapsular invasion. However, as you say, the criteria for malignancy of parathyroid lesions are very intricate, and sometimes they involve the loss of certain markers, such as parafibromin or menin in other syndromes or whatever else. But I did not make that diagnosis. It's not my my interest or my subspecialty training, but someone very competent in the field did.
Yeah, I remember I used to do head and neck pathology, and there was this old pathologist, I think Tom Delaney might, well, maybe not, Dr. Vickery, who was a parathyroid pathologist. He used to say, if you're thinking about making the diagnosis of parathyroid carcinoma, you should go outside, lie down, and wait for the thought to go away, because it's such a rare entity that you have to be absolutely sure that that's what it is before you make that diagnosis.
Absolutely. The other thing that's interesting in the beta version of the 5th WHO classification of endocrine organ tumors, a very high calcium level above 3 millimoles per liter and a very high PTH level, like 10 times the above limit of normal, are considered suspicious for carcinoma. So I guess it's a difficult diagnosis that requires a lot of input.
Okay, thank you. Vita, could you give me a short comment, please?
Yeah, just another confirmation of the pathological point of this case. Thank you for this presentation. It's such a classical situation which we kind of lost the ability to maybe to confront, to recognize the first moment, because it's so rare. currently. Before it was more common, and then it's more common that it's, you know, like here such a fulminant diagnosis of the parathyroid. And, you know, biopsy, frozen section, it just philosophy, I would say, you know, frozen section, you have to have, you know, kind of consequences based on your diagnosis, which is not given. If you have a core biopsy, it's better to prepare the operation and so on. So we also wouldn't even think about doing frozen section. So it depends perhaps on the setting and the definition what the consequences of the frozen section are. And then, you know, immunohistochemistry always, it's so easy, and then tumor board discussion. So if you have, you know, radiologists presenting you this large lesion and mentioning, you know, there are other osteolysis, so the reflex, you know, of the pathologist check the blood. So very classical, very nice presentation, and very important that we think about it. Thank you.
Okay, thank you very much. Thank you very much, Sebastien, for nice presentation. And let's move to the second presentation by Piotr.
I have two cases of soft tissue sarcomas, locoregionally advanced, and I hope that you find it interesting. It's together prepared with Professor Mateusz Pałek, who is radiation oncologist from our team and also present in the faculty. And first, and it will be localized disease. So first is a young lady, you may see here, with the tumor age 23, with the right breast tumor 30 millimeters, was referred to in November 2022 to breast cancer unit, had very strong, you see the family history, but the biopsy was negative. And the lady, and it was also genetic testing for hereditary breast cancer. It was detected one abnormalities in this gene. And generally, the patient went to Spain, and it was diagnosed as a breast hematoma there. But finally, the biopsy was done, an open biopsy, in Spain in April 2023, and it was suspicion of sarcoma. She came very fastly to Poland, and we did pathological review. It was angiosarcoma, primary angiosarcoma of this, this breast. So the staging was M0. It was primary breast sarcoma. Maximal size was 12 centimeters in CT MRI with skin infiltration, ulceration. And of course, this is a question. How do you want to proceed in this situation? So pre-op neoadjuvant chemo, pre-op radiotherapy, proceed with surgery, plus adjuvant, plus minus adjuvant, and combination 1 to 3.
Has the patient been staged? A PET CT
Yes.
sample?
The patient was staged, and it was M0.
Thank you.
How bad was the ulceration? Like, did you have like active bleeding, large, big, soft tissue defect, or it was like a little bit of ulceration?
Little infiltration of the skin, but the tumor was large. You may see here.
Okay.
Before. Okay, so you see that there are huge difference in the responses.
Mm-hmm.
So I show.
So, okay, can I read it? Can I read it? 36% answered the pre-op and neoadjuvant chemotherapy, and 28% answered to proceed with the surgery plus minus adjuvant therapy, and 20 people say that the combination 1 to 3, and 16 doctors say that the pre-op radiotherapy.
Okay, of course, we had MDT for this patient, and we finally, you see the tumor, we finally decided for number 4, so combination of pre-operative modalities. And you see the tumor, the skin infiltration was not very high, but it was. So we decided for 3 cycles of doxo plus ifosfamide. We also used, because we have this schedule, hypofractionated radiotherapy, and thereafter patient went to surgery. It was mastectomy with pectoral major muscles and skin graft, and delayed breast reconstruction is planned. Resection was finally R0. Good clinical response to therapy. I will show it pathologically, and wound healed without any significant consequences. This is the scheme which we use. This is one of our phase 2 clinical trial done also together with Professor Pawek, who is here. So we started from doxo-IFO. We had a hyperfractionated radiotherapy and thereafter 2 cycles of doxo-IFO. And you see the planning. Now we are using 5x6 grays, but maybe Mateusz, you will comment about it.
Okay, now we, because of more recent studies published some last years, so we decided to increase the dose to the margin and also increase the dose inside the tumor, because now we have some evidence from all other phase 2 trials that it's also a feasible and safe treatment, because after 5x5 we have around 81% of local control, so it is a bit lower than we expect. So with higher dose and better dose conformity, we can achieve probably better results. And we have right now very good experience and also very favorable toxicity profile and good pathological responses. That's important after the treatment.
Yes, that's true, and it happened here. This is the final pathology report. Sorry, there are some part of Polish, but I did a summary in English. So angiosarcoma of the right breast after treatment. The final size was 8 centimeters. We started from 12 centimeters according to ERTC STBSG response score, which was grade C. So it was the final evaluation according to AGCC 8 edition, and the patient is fine now. So, but of course, this is not a long follow-up. Still, that rare situation, wrongly diagnosed in young lady with strong history of the breast carcinoma, but finally it was primary angiosarcoma of the breast. Any comments?
Thank you, Peter. And so is there any comment from the
Very nice treatment.
medical?
How's she doing at
Yes,
this point?
please. Sorry, Tom?
Very nice treatment. How is the patient
thank you.
currently doing?
Good, because everything was healed, and if everything will be okay, so we plan in some time the reconstruction. But of course, we have to use the own muscles, not other. So we discussed with the plastics, and they want to wait a little bit because still it's highly aggressive tumor, and we can have relapse of the disease within 1 or 2 years. So Hanna wants to add something from our team as well.
Yes, because I gave the chemotherapy treatment to this girl, and I decided to give her doxyphosphonate and not paclitaxel. And I wonder if you have any comments on that, because this is a high-grade angiosarcoma. It's a breast angiosarcoma, but the skin was also involved with ulceration. She had a very nice response to the treatment, but still it is quite toxic treatment.
Okay, thank you. And Eva.
Piotr, I might have missed it, but you mentioned that there was a CMYC expression or even amplification, I don't know. And was there breast cancer before? Did I miss that? Did she have had breast cancer up front in her own?
It was not breast cancer, it was excluded.
No, I just mentioned because you mentioned at the beginning that there was.
I mentioned that she had a
from the whole family. They had all
yes,
breast cancers. Okay.
Family history. Many members of the family.
Okay.
So everybody thought that it's in breast cancer unit, that it's breast cancer.
Okay. I understand. Thank you.
Okay, Peter, please.
So, well, impressive case. But I'm always very reluctant, you know, being too optimistic if the pathological response is good to the adjuvant treatment, because, well, no adjuvant treatment, because usually it happens in very aggressive tumors. So how long is the follow-up? So I would be very reluctant to have this is a good prognostic factor.
Yes, now it's about 4 months of only, because she started treatment in April or May last year. We can check. So yes, it was, and you see very young lady, 2000.
Does anybody perform grading on these tumors? I can say I don't, never.
No, they are all
okay.
high grade.
Okay.
Well, and you know, it depends. 1 centimeter looks like hemangioma, and 5 millimeters.
The question of grading is interesting because you probably remember in the early 90s, Dr. Rosen, then at Memorial Hospital, published a series of primary breast angiosarcoma, and you know, not radiation induced, and it's been there for 30 years. That it's the only type of angiosarcoma where grade appears to be associated with prognosis. So the question is quite interesting. I must admit, I tend not to grade my angiosarcomas at all, but it's still in the literature to my
same.
As far as I know.
I never grade them because I think personal experience that they are really always going bad. I mean, even the small ones.
You can be right, but probably we should be aggressive in these tumors, because in other way we haven't any chance to help such lady. So Josephine wants to add something, probably.
Oh, hi. Yeah, and there's a very recent paper from Memorial Sloan Kettering from the group from Dr. Antonescu. They proposed like a 2-tier grading system for primary breast angiosarcoma. And they have like a sample size of 49 primary breast angiosarcoma cases. So yeah, I'm not sure there's like a good consensus regarding whether or not we grade primary breast angiosarcomas and what grading system do we use. But at least there's this like additional recent paper after the Rosen 3-tier system.
I grade angiosarcomas, and I think, and I agree with, she missed the last speaker, that I never understood that. I mean, they can have variable morphology, but if you have the ones that look like hemangioma, basically, that without the infiltration and etc., it can be even difficult to make the diagnosis, versus the high-grade epithelioid angiosarcoma. I just have a hard time believing that they're going to behave in the same manner. That's number one. So it's very controversial, should be graded or not. The study that said they shouldn't be graded, a lot of the cases were consultation practice cases. So there's always question about studies like this, because patients are treated differently in different institutions. There was also, I think there was, someone looked at our angiosarcoma of the breast, one of the radiation oncologists, and the grading did have some prognostic factor. The other thing is, I was going to ask, I guess the question was asked, is why did this tumor have c-Myc amplification? It's because, I mean, it's very rare for primary angiosarcoma to have MYC amplifications, usually post-radiation. So
it was done only, in this case, we did only with immunohistochemistry, but it was positive, that's true.
Okay.
Okay, Peter have 2 more cases. You have?
No, I have 1, and Hanna will go. So second my case, it's a localized by oligometastatic case. I hope also interesting, also rare location, because male, age 57 years, and had the symptoms in September 2022, headache, and in ultrasound of neck vessels and large tumor in the left thyroid lobe was detected. It was suspicion of anaplastic thyroid carcinoma. The patient was referred to the Department of Endocrine Tumors, and it was core needle biopsy. But finally, after relatively long different tests with molecular tests, immunohistochemistry with our reference pathologies. We confirmed pleomorphic sarcoma high grade. Staging was a large tumor on the left thyroid gland plus single lesion in the right lung. I will show you. And it looks in this way. It was initial tumor. And this is one of the NGS. We haven't found any specific abnormalities. And this was this lung tumor, right lobe. And how do we want to proceed here? It's a question. So we have 5 answers. So pre-op neoadjuvant chemotherapy, pre-op radiotherapy, proceed with surgery plus minus adjuvant therapy, combinations 1 to 3, and best supportive care, palliative care only.
So far, we have now half of the people, half of the answer will be the combination 1 to 3, and pre-op and the head neoadjuvant chemotherapy, pre-op radiotherapy, so blah blah blah. Okay. Peter, go ahead, please.
Of course, we have MDT. We have no doubts with colleagues from endocrine tumors department, but we have to start from chemo because of the metastatic disease. And so it was again tricky together with them. So it's the history. So we started again from doxo-IFOM. It was a vascular surgeon's consultation with obstruction of internally jugular veins. So the patient started apixaban and second cycle, and we decided to give everything for this primary tumor. So we, Mateusz will comment about it. We had a radical radiotherapy with deep hyperthermy, and this because of this radiotherapy, which was normally fractionated, we did not use doxo. We used high dose IFO in this situation. Radiotherapy was finished. We gave another cycles of chemo, and we had the response of the tumor. So radical surgery due to regression of primary tumor, left lobe of the thyroid gland was removed with tumor lymph nodes, and it was the final diagnosis and grade C response, 8% of live cells of the tumor, minimal margin 1 millimeter. It was done by our colleagues from endocrine department. You see the response. And this is postoperative fluid collection, and it was planning to radiotherapy. Maybe Mateusz, you want to comment something about it?
Yeah, it was very individual treatment because, of course, it's not standard case. It's not sarcoma of the extremity of superficial truncal, and we did not use hypofractionated regimen due to risk of late toxicity. After the treatment, and for example, a tracheal stricture. So we decided to go with a conventional fractionated radiotherapy, and we had and we still have an opportunity to use deep hyperthermia to increase the response of the tumor to radiochemotherapy. And there was also kind of problem with how to proceed with elective margin because there are no guidelines to do so. So we decided to include at least the whole thyroid gland and neighboring lymph nodes. And the treatment was well tolerated. The only toxicity we observed was esophageal toxicity like dysphagia and some pain during swallowing. But after that, the patient was fully recovered, and from late toxicity, we observed some hoarse voice, but it could be also caused by surgery, not only by radiotherapy.
Okay, thank you. Patient continued chemo after surgery of the primary tumor, and in August this year had radiotherapy on metastatic lesion in the right lung, and also please comment this.
Yeah, so we decided to proceed with stereotactic body radiotherapy similar to those the patient receive if he had lung cancer because it was central tumor. So we decided to use 8 fractions, 7.5 grays, with of course some respiratory movement control. The treatment was extremely well tolerated.
Okay. So this was this tumor which a little bit responded according to evaluation of our radiologists to chemotherapy, and this way decided to undergo it with radiotherapy. So it looks, and this is contouring by our radiation oncologist team, and this is SBRT, and and it was the primary diagnosis. So we decided to show it because it was absolutely individualized approach without any good good algorithms what to do in this case, but at least at this level we are successful with this patient. We'll see. This is this is 1 month after the treatment, but the treatment lasted long time, as you may see here.
Okay, thank you. We have just only one comment. Do you have any one comment because of the time limiting? Do you have the comment? Okay, let's move to the final presentation from the Hanna.
My name is Hanna Kosela-Paterczyk. I'm a medical oncologist working in Warsaw together with Professor Rutkowski. And I wanted to show you 2 short cases of patients with advanced leiomyosarcoma. I hope that they will be interesting for you. Case number 1 is a young patient, a refugee from the war in Ukraine. She had a large tumor on the right chest wall and also coming to the arm. She had pains requiring opioid use and limited limb mobility. She had 2 biopsies outside of our center, which were not conclusion, but this tumor was growing for at least half a year. The most important information in the history of this patient is that 20 years ago, she underwent radiotherapy to both axillary regions due to Hodgkin lymphoma. But because it was done home, we have no information about the doses that were used. We can only suspect. So here you can see the tumor prior to the treatment. As you see, there's a large mass in the chest wall and also in the armpit with ulceration and necrosis. The biopsy in our institution showed leiomyosarcomas grade 1. And here are the CT scans of the patient. As you see, a large mass in the upper thorax invading the adjacent muscles. But what was, I think, the main problem in the patient, that the patient was at start metastatic. She had a large 4 centimeters mass in her right lung in the apex. So I wonder how would you proceed with the patients? So with this radiotherapy-induced leiomyosarcoma, metastatic to the lungs, would you only give her surgery? Would you only give her palliative chemotherapy? Or maybe you would think about radiotherapy to the lesions, or maybe chemotherapy and radio, or maybe something you have another idea for this.
25 answers, 27 answers. Around the half of the answer is chemo, pre-op, and surgery to both primary and med.
Okay, I'm glad to hear this answer because, as you will see, our idea was quite similar. But take another slide. The next slide. Oh, sorry. So because I'm a med-onc, I'm very curious, which chemotherapy will you use? Would it be DOX alone or DOX plus ifosfamide, that is a leiomyosarcoma, DOX plus the carbazine, or maybe something gemcitabine based, or maybe you have another idea of that?
That's interesting that the almost half answer that the DOX plus dacarbazine is the main mainly performed in the European countries, and also 32% performed the DOX and IFO. DOX and IFO.
Yes. Can I go to my
Is it
next?
okay, Hanna?
Yes, but I can't go to my next slide. Oh, so because we don't give ifosfamide in Warsaw for leiomyosarcomas, it doesn't work. We give doxorubicin and dacarbazine in patients with leiomyosarcomas, and this was our decision also in this patient. She received tox plus TIC. So maybe the tumor, when we saw it, wasn't very smaller, but the patient reported that she had less pain and more arm mobility. We had to reduce the dose slightly because of liver toxicity, and she had a CT scan after her third cycle. She was stable within the primary lesion, and there was a slight decrease in the metastatic lesion. And then Professor Rutkowski performed the surgery on this patient. He removed the sarcoma with the adjacent muscles and covered everything with free skin graft. This is the picture from the lesion after the third cycle. As you see, we don't see many change when compared to the first picture, maybe slightly smaller in terms of the necrotic part. But here you can see how the big was tumor within the chest wall. So in terms of pathological examination after the surgery, it was a large 20-centimeter sarcoma with not a very satisfying response to the pre-op treatment. Not a very good response, but it was taken out completely, an R0 resection. And it was a leiomyosarcoma, high-grade leiomyosarcoma in the final pathological examination, which I think when you see the tumor, when you see the metastatic lesion, it's more probable the grade 3. The patient is in a very good condition with no complication in terms of surgical complications. She has a good mobility in the arm. So we continue the chemotherapy. We tend to use quite a lot of doxorubicin, and within the breaks between the cycles, the patient had the tumor from the lung taken out. It was also an R0 resection. It was metastatic leiomyosarcoma. So the patient is on follow-up, doing well. We'll see what will happen. The follow-up is also short. I don't know if you have any comment to this case.
So, is there a comment from the audience or panelists? So, how do you think? So, Tomoki, do you have the experience about the leiomyosarcoma, and which chemotherapy regimen for the leiomyosarcoma? As
thank you for the nice presentation. Usually we use doxorubicin and ifosfamide for the leiomyosarcoma, but I wonder if some chemotherapy was received when she developed the lymphoma. So how about past history of the treatment when she received the radiotherapy? 2006?
She did not receive chemotherapy at that time. That was our first question, of course.
Yeah.
It was a locally advanced, not such a big Hodgkin lymphoma. She only received radiotherapy to both the axillas. This was, of course, our first question.
But she, of course, but she was treated in Ukraine, and we do not know all details because she is a refugee of war in Poland.
Okay.
Hanna, it's Andrea from Brazil. Did you consider radiation in the course of the treatment?
Maybe Mateusz, if he's still there, would answer the question. The patient did not receive radiotherapy. We had no idea what doses she received previously.
Yeah, the problem is that probably in the Ukraine they used mantle field with very old radiotherapy techniques, and we are not very sure how much dose, for example, was given to the spinal cord. Of course, we can, and also for brachial plexus, of course, we can re-irradiate. We will consider it after the completion of chemotherapy, but another factor against it is that she was and she is metastatic. So when she had only primary radiation-associated sarcoma, will be more in favor probably to give radiotherapy than in the situation of metastatic disease, because there is a risk of accumulation of toxicity after the treatment. But nothing is excluded.
Okay, thank you.
Okay. So when she finished his chemotherapy, so is there any maintained treatment?
She completed her chemotherapy. We gave her all the dose of doxorubicin she could get, and she completed the treatment already. If this was your question.
Okay.
So she was on follow-up with no signs of the disease.
Yeah. Okay, Hanna, let's move to the next case.
So the next case is retroperitoneal sarcoma. This is a 65-year-old male. He's a surgeon, so he had some pain in his abdomen, and had a CT scan which showed the sarcoma in the retroperitoneal space. It was 9 centimeters in size, and in the biopsy showed high-grade leiomyosarcoma. As you see, the tumor here, it's maybe not so big for retroperitoneal sarcoma, but it has a very bad location. Adjusted to all the veins and mainly to the superior mesenteric veins. So my question is, no metastatic disease at the time, it was his only lesion. So my question is, how would you proceed? Surgery only, palliative chemotherapy only, maybe radical radiotherapy, all of the above, or something else maybe?
Okay, for the treatment strategy for the retroperitoneal sarcoma, and the surgery only, and all of the above. So the comprehensive treatment is the main answer of this poll.
And no one would give radical radiotherapy to the lesion. Okay. So we discussed the patient on our MDT, and because of the infiltration of the superior mesenteric vein, I know that the CT scans I showed you were very small, and the decision of the primary surgery is in the vast majority of patients a good decision, but in case of this patient it was impossible because of the infiltration of the veins. We also presented the case of this patient on the TARPAS MDT boards, and there was an agreement with our decision in terms of the unresectability of the tumor. So we gave him chemotherapy, and we'll see. This was the decision. So he began chemotherapy again because this is a leiomyosarcoma. He received dox, the TIC, no ifosfamide. And after the second cycle, we saw a slightly decrease in the tumor size, but still it was unresectable. So we decided to give him radiotherapy to the lesion. Maybe Mateusz will comment on that in a moment. And also the patient received hyperthermia together with radiotherapy. And after he completed his chemotherapy and radiotherapy, he had another CT scan and showed a decrease in the tumor size and the tumor with not such a vein invasion. So the patient went a complex resection of the tumor. It was a very large surgery with vessel reconstructions. The spleen and the pancreas were gone. The resection was R0. The lesion was 6 centimeters large at the pathological examination, and there were some signs of the response to the treatment. So it's also a very short follow-up. But I think it's a nice case on the primary unresectable leiomyosarcoma, which tend to be resectable. Thank you. I don't know if you have any comments on that, or maybe Mateusz, if you would tell about the radiotherapy.
Can you just step forward to
Yes.
fractionation?
The radiotherapy.
Yeah, it was a very difficult decision for us. I consulted the case of this man with my colleague who is experienced in GI radiotherapy, and we decided to use kind of simultaneous integrated boost and both with integrated protection treatment, similar to those we can offer a patient with pancreatic cancer. As a result, we give relatively very high dose to the tumor to increase the chance to make it resectable after that. Of course, as we have access to hyperthermia, so we also gave this treatment to to this patient, and the treatment was also well tolerated, despite very high equivalent dose. So it was 15 fractions per even for grays per fraction, up to 60 grays per GTV, and only some nausea and diarrhea after that. But as I know, no surgical complications also occurred. So it was probably a good decision to also apply radiotherapy.
And that's all.
Okay.
Thank you very much.
Thank you very much for wonderful cases. So demonstrated that the hyperthermia is the effective case of the hyperthermia. Thank you very much. Okay.
So may I have a question? May I have
yes,
one
please.
question? Yes, more question.
Yep.
So for this kind of retroperitoneal malignancy, so which kind of a biopsy you like to choose? Is needle biopsy or something otherwise? So for this
needle
biopsy.
Core needle biopsy under ultrasound or CT guidelines. So it depends.
It's from anterior or you got it from the posterior approach, I mean, for the biopsy?
Yes. For this one, yes.
Posterior, right?
Yes. But
Okay,
not always. Of course, it depends on the location of the tumor. So generally, this is for complicated tumors, it's done by our radiologist.
Okay, thank you.
Okay. So the last but not least, Santiago will start the presentation.
Yeah. So sorry, but
yes,
we have clinic at 12 and all that. Like we really ran out of the time. This was scheduled to be until noon. It's for an hour, so I don't know if we're going to have the time. Like maybe we move it for next session. I mean, it was supposed to be one case per group, and I don't know. Like I will have to fly through this like in 5 minutes to finish on time. What do you prefer?
No. We have we will end within the 15 minutes.
Okay.
Mm-hmm.
Let me. Can you see my screen?
Yes.
Okay. So we're going to discuss a case that was interesting in terms of the diagnosis and the path that we have to get to make a final diagnosis. So this is a 27-year-old male that had a painful mass in the anterior aspect of the leg for 1 month, no history of trauma, no systemic symptoms, no significant medical history. The only relevant oncologic history is that he had a cousin with a malignant peripheral nerve sheath tumor. And these are the initial x-rays. So I don't know if Alex is around or Manish. Do you guide this for diagnosis of osteosarcoma, or do you will look at this with like some suspicion? What do you think of those x-rays?
Yeah, I think sorry, go ahead.
Yes, please.
Yeah, when I look at this, I think that given the age and everything, osteosarcoma is certainly a consideration, but it has more of a diaphyseal location. So I think by definition, you start thinking about, the Ewing family of sarcomas as a consideration. But either way, it's got imaging features that would be suggestive or concerning for malignancy. So I'd also get advanced imaging, but diaphyseal bone location that would raise, despite the age, would make me consider Ewing's in addition to osteosarcoma.
Correct. So this is a high power, or like a closer view to the tumor. So it looks like he's forming bone and it has some periosteal reaction and some burst pattern. This is the MRI. This is the T1 sequences showing the involvement of the cortex, heterogeneous on the T2 sequences, and heterogeneous on the sequences with contrast. I think that you will agree that this will increase the concern of Ewing sarcoma. Andre, Manish, would you agree with that? Any comments to add on the MRI?
Well, it looks like it has periosteal reaction actually, but you in sarcomas usually don't have bone matrix on the X-ray or CT scan, so I would have to rule out a periosteal osteosarcoma. Perhaps would be another hypothesis.
Correct. So
well, it's a very solid periosteal reaction, which is very unlike an Ewing sarcoma.
But
Ewing sarcoma is more broken periosteal reaction.
Okay, on the other hand, it's a huge infiltration to the soft tissue,
Yeah.
so it can be lymphoma also, it can be something small cell tumor, but you cannot guess.
Correct. So we got a biopsy, and the initial read was that it was a small round blue cell tumor. And then you started to think about other things, as Piotr mentioned, lymphoma. The patient completed his staging, got a PET, got a CT, no evidence of metastatic disease, and this is the pathology. So I think Dr. Nielsen is in.
Yeah, I have to do this quickly because I had coverage until 12 o'clock in the frozen lab, so I'm getting paged already. So anyway, it's a, you can see on low power, it's a malignant neoplasm, a lot of fibrosis, small round cells. I guess next slide. I can't control. Higher power, again, obviously malignant round cell tumor. Next slide. And the cells look very similar, have a finely dispersed chromatin. Some of them might have small nucleoli, but nothing specific based on the H&E, basically a round cell malignancy with a large differential diagnosis. Next slide. CD99 showed what appears to be somewhat diffuse membrane staining. Next slide. And NKX 2.2 showed a lot of nuclear positivities. Obviously, it's consistent with Ewing sarcoma. However, next slide. Oh, I guess Santiago moved the slides around. Anyway, the gee, this is what happens when they let orthopedics.
Just to be sure if you're awake.
Show your pathology slides. So the molecular came back with HEY1 NCOA2 fusion, confirming the diagnosis of mesenchymal chondrosarcoma, where the biopsy did not show any of the cartilaginous component. If you go back to the slide and look at it retrospectively, you could have sort of, because of the nested pattern, wondered about that diagnosis. And when I got the fusion back, go back to the NKX3-1, I did stain for NKX3-1. As the pathologists know, it's sort of a controversial, whether it's a marker for mesenchymal chondrosarcoma or not. There have been papers saying it's helpful or not helpful. In the few cases that I've stained, mesenchymal chondrosarcoma has been positive for NKX3.1, which is also used for prostate cancer, and all the Ewing sarcoma that I've stained so far have been negative. So in a round cell tumor, when it's possible you might use that as a sort of a marker in the differential diagnosis. Next slide. Next slide. So basically, mesenchymal chondrosarcoma, as you know, is a high-grade malignant. It's a biphasic tumor that has a primitive round cell component and then organized cartilaginous component. And almost all tumors do have this particular type of fusion and do not contain the IDH1 or 2 mutation that are characterized for conventional chondrosarcoma. And immunohistochemically, they usually CD99 positive. They can be SOX9 positive, which I don't think a lot of labs have SOX9, S100, NKX 2.2, which is also seen in Ewing sarcoma, are frequently positive in mesenchymal chondrosarcoma. Then the question about the value of NKX 3.1. And they can also show variable expression for other markers, including desmin, myogen, and MyoD1, all indicating some skeletal muscle differentiation. Next slide.
Okay, so these are treatment options. So surgery alone, neoadjuvant chemotherapy, surgery, adjuvant chemotherapy, chemoradiation, and surgery. If radiation, will you do it pre-op, post-op, of both?
Show that the 24 the answer is correct, and the neoadjuvant and the surgery and adjuvant treatment, radiotherapy, chemotherapy and surgery is the most major answer.
So that's what we decided to treat the patient. The use of chemotherapy and these mesenchymal chondrosarcomas of bone is controversial. There is different research that has not shown substantial benefit, other that shows some benefit, and I'm going to go over that a little bit. That's what we did for the patient. And basically, after he completed the radiation, which was basically a Ewing sarcoma-like treatment with 5 drugs compressed, he got 5 cycles pre-op, 7 cycles post-op, and the plan for radiation was if there was going to be a positive margin. This resection was challenging in terms that the anterior tibial neurovascular bundle was affected. We did an intercalary resection. We obtained negative margins and reconstructed this with a combination of carbon fiber implants, which is my preference, and photodynamic nails. However, there is no carbon fiber implant for the distal tibia, so I have to use metal plate, but I try to decrease the amount of metal for subsequent MRIs and CT scans for follow-up. This is post-op of the patient. This is done like 3 weeks ago or so, so he's now getting his post-operative chemotherapy.
So this is the resection specimen. The tumor is involving in the medullary cavity, so it's a primary intraosseous tumor with a soft tissue component, has a sort of a fleshy looking appearance, and it's demonstrated an infiltrated growth pattern both within the medullary cavity and within the cortex. And oops, next slide. And oh God, Santiago, you removed slides. Is there one more?
What you sent?
No. Is there one more? Yeah, this one's supposed to be before.
Okay.
Anyway, so most of the tumor we put in a lot of section. The 90, probably 5% of the slide you showed this malignant round cell component with this sort of branching vascular pattern, somewhat nested, somewhat what you see in mesenchymal chondrosarcoma, and they did not contain any of the cartilaginous component. If you go one back, there were only a 2 or 3 slides that showed nicely the cartilaginous component you can see here on the left, juxtaposed to the round cell component, obviously diagnostic for a mesenchymal chondrosarcoma.
So this tumor was initially described in 1959 and is one of the rare subvariants of chondrosarcomas. As pointed out, is composed by the small round blue cells in combination with the atypical cartilaginous cells. There are some subvariants, one that is more predominant in females, and therefore is at the base of the skull, that we have extensive experience in managing with radiation, giving the possibility to resect some of those masses. And we're fortunate that we have Tom Delaney here to give some comments on that. There is the soft tissue variant, which is up to 50% of the cases. And the bony one simply behaves more aggressively than the other chondrosarcomas. The last literature review was done by Dr. Guo's group based on 11 case reports, 1 retrospective study with 88 patients, and 1 prospective one with 6 patients. And then basically the conclusion of that literature review is that patients with a localized disease do better than those with metastatic disease. Those that have involvement of the non-axial region do better than those with involvement of the axial region, the spine, the pelvis. There is an impact of age. Younger patients than 30 tend to do better than those that are older than 30. Those that are treated with surgery seem to do better if the mass can be resected with negative margins. There seems to be a benefit with chemotherapy, but that finding wasn't statistically significant. But I would say that most centers will try to approach this as a Ewing sarcoma-like tumor. And I think the important one is margins. And if you cannot get a negative margin, using radiation postoperatively can help you to obtain the same rates of local control, but not having an impact in overall survival. So it's a more aggressive tumor. Is usually a diagnosis of exclusion. Very important to get negative margins in here. And good to take into consideration radiation if you have a close margin or a positive margin in situations in which you cannot use complete resection. And the chemotherapy, I think most people will argue that it's important that you have ifosfamide in your protocol and have a kind of like Ewing-like protocol. So I don't know if Tom, maybe you want to elaborate a little bit on the base of the skull and the experience with radiation.
Can I just make one comment before Delaney? Is that I forgot to mention that the tumor was completely viable. It didn't respond to chemo at all. It was basically maybe 1% necrosis, which could have just been. So basically chemo had zero effect, at least on the primary tumor.
Oh, that's interesting, Peter. I think most centers that I've looked at have used a Ewing's regimen for this disease, in part because many of the patients are young patients, and it has a round cell component. And I think, Santiago, as you mentioned, radiation has been used for patients who have either unresectable lesions or as adjuvant for positive margins. The radiation dose in a series we had looked at, the median dose was about 60 gray. So again, in the range of Ewing's, or perhaps slightly higher. And I think in this case, I agree with the decision that if surgical margins were negative, I would not add any additional adjuvant radiation. And as you mentioned, I think the major problem with this disease is the development of distant metastases. And as Peter alluded to, and not all patients respond well to chemo.
Any of your orthopedic surgeons will do something different than the intercalary allograft? Or if you use intercalary allografts, do you have a preference for modes of fixation, intramedullary rods, metal plates?
Yeah, here at the University of São Paulo, Brazil, we use allografts. But I would do just one thing different from you. I'd put at least one of the plates covering both osteotomies. You know what I mean?
I see.
That's the only remark. Other than that, we will do exactly the same.
So I didn't do it because I have an intramedullary device on top. So that's why I didn't go that high. Like this guy is very tall and the plate wasn't as, like that was the longest plate that I could get. So I just kind of like use the intramedullary photodynamic nail and interdigitating. But if you can, totally agree. Ideally to have a region of both osteotomies.
I will go with the autograft with the nitrogen treatment, but we don't, unfortunately, we don't have the allograft. But no, it's a very interesting case. And I remember correctly in an NCCN guideline described that the round cell tumor chemotherapy regimen is a high recommendation for this disease, is it?
So it is controversial, and like some centers even won't use it. But I think when a center use it, basically is they treat it as a small round blue cell tumor and use it as a Ewing sarcoma.
Okay.
But then you have a case like this. He got all that chemotherapy and the necrosis was zero. And we're giving him the same post-op because there is nothing else to give him. So I mean, the hope is like any little cell, maybe at the higher dose, like will die and hopefully he won't get metastatic disease. But
okay, margins are very important message for every surgeon. Okay, thank you, Santiago. Really appreciate that. Thank you.
Thank you. Thanks for the time, guys.
Thank you very much for everybody. So it's going to be a very fantastic night and day and the meeting. Thank you very much. Okay, we'll close the session. Thank you.